stay for the whole session as I've got to speak elsewhere, so I apologise that I will have to leave halfway through. But I'm going to talk about vasopressin and its analogues. My disclosures are here for you all to see. And this is a pipeline discussion. I thought that what I should probably do is do a bit more horizon scanning, where I think we'll go in the future rather than where we are right now. So my plan is to talk about when I think we should be using vasopressin, why, some other areas that why we might want to use it, but particularly trying to focus on in who is going to get the most benefit. And then finally, I'll talk about some newer analogues at the end. So at the risk of spoiling my talk tomorrow, talking about vasopressin's place, I have to summarize where I think vasopressin is used now, the way I use it in my practice. I use it as an adjunctive vasopressor. So if the dose of norepinephrine is rising, I add it in. I think we should use it earlier rather than later. And particularly earlier if there's renal function developing or if you have trouble with arrhythmias and tachycardia. But can we do better than this? This day we all talk about precision medicine. Are there patients that we can identify who might particularly benefit from it? And this recent study just published a few months ago has tried to look at that. It's an observational study. They've looked at patients who were given vasopressin. And they've tried to identify those factors that were associated with vasopressin response compared to the non-responders. And their definition of response was that your blood pressure went up by at least 10 millimeters of mercury, or you were able to wean down the catecholamines after at least 30 minutes. Now, it's an observational study, and they did multiple logistic regression analysis, and they found that basically vasopressin seemed to actually work better if you gave it as an adjunctive therapy rather than using it as a sole therapy. So as I think most of us are using it. Interestingly, the female sex seemed to be associated with a greater response, particularly in the septic patients. I'm not sure I know what that biology might be. I mean, this is an observational study, so it may well be some other confounding factor, but it's interesting. But anyway, we're trying to identify patients who might respond. So I think with all our therapies, we're trying to give them to the patients who are likely to benefit. So this is one way of giving it as an adjunctive therapy. And I'm going to look at other ways we might identify who might benefit. I'm going to go slightly off-piste rather than talking about its vasopressor action, and is potentially about immune modulation of our drugs. And we know that many of our therapies that we give for another reason may have immunomodulatory effects, and this is important. I know there's a talk later about immune modulation. But this review article published in the Blue Journal last year, highlighting some of the issues around of vasopressors, and particularly here, and just this example I've shown, is around monocytes, and how either alpha or beta adrenoreceptor stimulation can lead to either elevation of inflammatory cytokines or actually depression. And so the different catecholamines, different agonists we gave, may change the immune status of the patients. And this has been looked at with the use of vasopressin. Jim Russell and Keith Wally have led a lot of this work using the VAST data. And then in this study, where they've taken the patients from the VAST, taken a multiplex cytokine array, measured multiple cytokines, and you can see here they've grouped them and how they group together. It's quite complicated, but I think there's a simple line when it comes to the vasopressin treatment. They summarize that the patients who were randomized to the vasopressin arm in the trial, over that first 24 hours, there was a greater reduction in these inflammatory cytokines with vasopressin treatment compared to the norepinephrine. So suggesting that maybe there'd be effects outside the hemodynamics, and maybe this identifies patients who may benefit from it. And this sort of comes with their recent paper with the new sepsis definitions and the definitions of septic shock. They've gone back and looked at the VAST trial and looked at how that affected the trial results. And they found that it was the patients who had the lower lactate levels where they got the benefit, and particularly in the less severe shock, which was obviously the original finding. And they broke it down into the different groups, but I highlight here, if you had the more severe shock, and particularly if you had the lactate above 2, you didn't seem to get any benefit from giving vasopressin. But they found in this group of patients who were clearly sicker that they had higher levels of cytokines when they measured them. It's not surprising, they were the sicker patients. But they go on to suggest that maybe it was then in the patients with the low level of cytokines, if vasopressin is having effect the ones with the lower levels might be the ones who benefit. And I suppose that makes sense. Vasopressin is not primarily an immune modulating drug. We give it for its vasopressor effect. It has weak immune modulation effect if it has any. Therefore, you might only, if there is additional benefit, you might see those in the patients with the lower levels. So I think it's an idea of identifying who might benefit from drugs and being realistic about who could get the benefit. We've been looking at the similar sort of things. This is work from one of my PhD fellows presented in Brussels, just in abstract form, taking healthy monocytes from volunteers, incubating them either with or without LPS, priming, and then looking at their response to endotoxin. And interestingly, when he gave noradrenaline, there was a drop in TNF release. High-dose vasopressin led to more TNF reduction. But the combination of the both, norepinephrine and the vasopressin together, gave the most suppression. So again, supporting the idea that maybe these drugs are working in combination, and we're giving both is where we may see the biggest effect. So that's, as I said, going slightly off-piste around immune modulation. What about the other effects that we all know, the hemodynamic effects? Well, the Surviving Sepsis campaign says that you can give vasopressin and expect it to reduce norepinephrine requirements. It says there's moderate evidence. I think it's pretty strong. I think it does work as a vasoconstrictor. It does put up your blood pressure and spares catecholamines. So this was the data from 800 patients in VAST, where you could see in the red, patients treated with vasopressin, norepinephrine's coming down more quickly. This was our VANISH trial we published last year in JAMA, 400 patients, and you can see on the left, blood pressure is identical in the two groups, but again, blue, patients given vasopressin, significant norepinephrine reduction. And that may be a benefit, for particularly if you want to avoid catecholamines, and particularly around heart rate. As we know, people are talking about using beta blockers now. But maybe rather than beta blocking, we can just avoid giving so many catecholamines. And so this was the data from the VAST trial where we looked at the hemodynamics in more detail. And you can see heart rate here over the first 4 days is coming down significantly with the treatment of the vasopressin. We don't know whether that's a direct baroreceptor response, or is it simply removing some of the beta agonist effect that norepinephrine has. But you can see that heart rate coming down. And particularly when we broke it down into the more and less severe shock, you see there was quite a striking difference in the less severe shock. Again, the patients who weren't so ill. And again, if you think about it, vasopressin is not a beta blocker, and it's the patients who are less ill who may be getting this benefit from a reduction in the heart rate where you saw it, and that was the group where the mortality benefit. So maybe there are ideas around who might benefit from the drug. But that's on clinical grounds. Can we do anything else? Well, could this be an area for pharmacogenomics? And there's quite a lot in the literature around adrenoreceptor polymorphisms and how they affect response to catecholamines, vascular reactivity here from cardiology literature. This is the beta-2 receptor polymorphisms. There's stuff in the beta-1 receptor, again, suggesting a differential response to catecholamines. And even ones within alpha receptors, suggesting there's an increased risk of sudden cardiac death. Could this also associate with serious adverse events? So that's a cardiology literature. What is there in critical care? This is more anesthesia. So this is looking at hypotension and drug requirements after spinal anesthesia. And again, suggesting there's a difference according to your genotype and the degree of hypotension and the vasopressin you might need. And again, this has been looked at in the Vancouver cohorts that Jim Russell and Keith Wally have been doing according to genotype. And again, that same, using a tags polymorphisms that identifies that certain haplotype, genotype that is associated with reactivity, whether patients had a worse outcome in these two independent cohorts. Interestingly, when they added steroids in the patients who were given steroids, that sort of increased mortality appears to have gone away. Now, I do urge caution. It's very small numbers, so I don't think we should over-interpret it. But importantly, it wasn't just the mortality. That genotype was associated with higher heart rates, higher doses of norepinephrine, and reduced anti-inflammatory effects. So maybe there's something in the genetics. They've also looked at it with vasopressin receptors and polymorphisms there that affect its breakdown, maybe affecting its levels associated with difference in outcomes, or even suggesting that they may be associated with these adverse events. So maybe we could use pharmacogenomics going forward. Now, I have to say, I'll be honest, I don't think in 2017 any of us are going to be using pharmacogenomics to titrate or choose our vasopressor therapy. But it's going to happen soon that we're going to have devices such as this where we will be doing bedside genotyping, maybe to identify the bacteria. That's where we're going to, I think, in reality, that we will use genetics first at the bedside, identify the pathogens. But these devices can be changed, and they could measure human DNA rapidly, quickly. And once we've already got them in our ICUs, the price will come down, it will become more feasible, and maybe that is the future, the way we will decide. So, as I said, a bit of horizon scanning. What about other effects? I think there is an effect vasopressin has on the kidney, and we've seen in a number of studies a sort of consistent signal. So this was the original pilot prior to the VAS trial, 24 patients. They had the same blood pressure in both groups, but when vasopressin was added in, urine output went up in this 4-hour infusion. Another pilot study, 23 patients only, where the vasopressin was given very high doses, but for longer, 48 hours. And again, you saw an improvement in creatinine clearance, suggesting a beneficial effect in the kidney. In a post-hoc analysis in VAST, we saw that the patients who were at the risk category, according to the rifle criteria, had a reduction in creatinine and almost halved their rate of progression to renal failure or loss. So rates of dialysis halved in this subgroup of patients. And again, in the VANISH trial, although the primary outcome, which was days alive and free of renal failure, showed no difference, one of the secondary outcomes looking at rates of renal replacement therapy was nearly 10% lower. And that was accompanied with a reduction in creatinine. You see that again in the blue, it tended to be lower over time. So I think there is a signal suggesting at least some effect of vasopressin on the kidney, and that fits with the physiology that we know. But could we identify who therefore might benefit better? Rather than using creatinine, which is all we have in our ICU, there's talk about these renal biomarkers being available. Maybe again, this would be a way we would select who could get treatment with vasopressin. Again, this is becoming a reality with point-of-care diagnostics being available to us. Do we need to be smarter about how we select our patients for our various therapies? And then we might see some benefit from them. So these are ideas I think vasopressin may be going in the future. Just the last couple of minutes to finish up with other analogues. So vasopressin itself binds to a whole family of vasopressin receptors. It's the V1A that causes the vasoconstriction. And people have developed selective V1A agonists. It's celepressin that's been tried in here, in this case in an animal model. And when they compared it to vasopressin and norepinephrine, it had improved survival. And also, importantly, they felt there was less fluid leak and thought this may be of benefit. Just published, I think, this month in Critical Care, their early pilot study, phase 2A trial, comparing different doses. And you could see here that as the dose went up of the celepressin, they spared more norepinephrine, so the higher doses worked more effectively to restore blood pressure. And again, they saw the same signal, this time measured showing fluid balance, where there was less fluid given to the patients in the higher dose. So again, thinking whether it was preventing fluid leak. That led to the Sepsis Act trial, which you may know about, ongoing, a seamless phase 2, phase 3 trial with adaptive design. Started off with a certain dose finding study, potential to add in additional doses as it went on. And at 800 patients, there were rules to decide whether you went on to the next part of the trial or whether you stopped. And the phase 3 trial would go more what we're familiar with, RCT of drug versus standard of care, going up to 1,800 patients. So an interesting design. Also interesting that the FDA accepted an outcome other than 28-day mortality. So it's an outcome measure of organ supports and so on that was their primary outcome. So I think a very interesting trial. They've just updated their website, the clinicaltrials.gov, as of 3 or 4 weeks ago, and it stopped recruiting to the trial. I think it got to the end of that stage 2, and basically there was that stopping rule, and my understanding is it stopped on the basis of futility. No safety concerns, but they felt they weren't going to meet the threshold for carrying on to see any beneficial effects. So that has now stopped recruiting, and I think we'll hopefully see results from that next year. So I'll stop there. And just in summary, I think vasopressin is useful as an adjunct vasopressor. Maybe there are immune modulating effects. I think it's particularly useful if we want to avoid tachycardias and arrhythmias, and I think it does have some renal protective effect. I'm sure we can work out how to use it better, and this is part of precision medicine, which is, I think, the way we are definitely going to go. And the Vasopressin, I think, is obviously disappointing to hear the trial has stopped, but we wait to see the results, and it's another 800 patients treated with a vasopressin analog. Again, what do we see about its effect? And I'll stop there and happy to take any questions. Thank you.
Thank you, Tony. Any questions from the floor or on Twitter? I can't see anything here at the moment. Could I maybe ask you then, very challenging trials to do, aren't they, these, to actually translate into a clinical outcome and know that you haven't had a lot of muddying of the water with noise. How important do you think timing is in a time-critical setting? We think, for example, of the CRASH 2 trial, where the timing of tranexamic acid clearly was important in a narrow time window. Have you got any comments with vasopressin or these novel agents as to how we can take that forward in our setting of sepsis?
So I agree with you. I think timing is crucial. I mean, that was a part of the rationale with the VANISH trial, that when we did VAST, the average time from septic shock onset to getting the drug was 18 hours. And I felt that doesn't reflect clinical practice. And that whole idea of maybe the less severe shock patients benefit. And that was the idea with VANISH, we get in earlier. And we were able to do it within 3 hours, which I think is not too bad. Again, I know that people say, well, I can go to the cupboard in clinical practice and get it out. But, you know, there are realities of just how you manage that. So I think that getting in earlier, obviously it didn't show any difference in the primary outcome there. But again, I think importantly showed us that we could use it earlier. So I think that we do have to factor in time. If we're going to use biomarkers, that's why I think they also need to be point of care. That's why I showed you that little device that we can have these tests up in the ICU, and I'm sure we're going to go whether it be proteins or transcriptomics or DNA, I don't know, but the technologies exist now that we could do it rapidly.
Any other questions? Yep, from Richard Beale here.
Thanks very much. I mean, as a general rule of thumb, we regard vasopressors as certainly noradrenaline, as a necessary evil rather than being a good thing to do to people, and try very hard, hopefully, to reduce the dose as quickly as possible and wean it as quickly as possible. And we also know from the old LNMA data that effective sustained vasopressor effect isn't necessarily associated with a positive outcome. So I'd just be interested to get a sense for your feeling as to whether this is intrinsically a good thing to do, or there's a downside to this in the context of those previous experiences and those general principles.
You mean with vasopressin specifically, there's a downside to vasopressin, or with any vasopressor?
Well, this one in particular, how does this fit into that general previous experience? I mean, because as I say, we try to use them, don't we, only when they're necessary, but not to leave them on any longer than we need to, get rid of them quickly. We know that there's a downside to over vasopressor effect.
And I agree with all of that, and I think vasopressin is probably the same. I wouldn't use it when you don't need to use it, and you should get it down as quickly as possible. I think we've got enough data from it now to say it is relatively safe. Absolutely has adverse effects like all vasopressors do. In my talk tomorrow I mentioned I do think there's a slight signal for more digital ischemia, which you need to consider. Of all the ischemias you might get, I'm not sure that's the most important one. Mesenteric ischemia worries me more, and I have not seen any signal from that from any of the trials. So I am reassured that it is a safe drug to use when you have to, but absolutely don't use it more. And I think when you're getting to higher doses, for instance, I'll accept a lower blood pressure target, and we shouldn't aim too high because all of these drugs have side effects, so we should try and get them off as quickly as possible.
Okay, I think we need to move on to the next talk. Thanks very much,